Greetings, everybody. Audio working okay?
Yep.
All right, and then just remind me, Christine, do you forward the slides for me or do I control?
I can advance them for you.
That's great, Christine. Thank you. And Evangelina, Kelsa, and everybody else, thanks for your support. It's great to have so many people from VBI here. The vaccine world is hopefully going to change really soon. And I'm going to give just some introductory comments about the dynamic, the wave that we're riding. And that is pending ACIP recommendations to vaccinate all adults for hepatitis B. What's just behind that, and we're hopeful, so this is not guaranteed in any way yet, that there'll be a recommendation from the CDC and other governmental authorities to test all adults and all at-risk individuals for hepatitis B. There was a paper that was just published today about testing, and that testing paper, which I haven't read in detail, but Sherry was kind enough to send me a preview this morning by email, talked about it not being cost effective. And they're talking about going back to, and I'm talking about regression here, to a risk-based model using, quote, artificial intelligence. Well, our regular intelligence hasn't worked very well, so I'm not too optimistic about artificial intelligence for screening. Risk-based screening has failed miserably. So how can they talk about not being cost effective, but in the same breath advise something that hasn't worked? And we haven't used artificial intelligence for any screening process. So then they're talking about using something that's unproven to do something that has failed. So it's going to be a lot more dialogue on these fronts. And Sherry, thanks for your letter this morning. I'm going to look in much more detail into this in the next 24, 48 hours. Next slide, please. So from a disclosure perspective, I've been doing consulting work with VBI, a lot of telephone conversations as another vaccine is heading to market and FDA approval. Been doing consulting work for Dynavax in the past, and even more remotely, I've been working with SmithKline and with Merck on their vaccines, which are really, opened the really big door for hepatitis B prevention and as an anti-cancer vaccine from a preventative perspective, not from a treatment perspective. Next slide, please. So there's a big discussion about testing people for hepatitis B in general. And as you know, historically, it's always been about risk-based testing. And we know that risk-based testing has failed, and risk-based testing is not putting us on the path to the 2030 target of hepatitis B elimination. There is also discussions, are discussions about whether you test before vaccinating. I'm a very strong proponent of this test before vaccination. Sam So, which many of you are familiar with, has done phenomenal work, not just in the United States, not just in California recently, but in Asia and specifically in China doing vaccination. Millions of people have been vaccinated under this Jade Ribbon umbrella. And he was doing incident to vaccination, which means people come in, they get vaccinated, they're sent out, they might not get tested. But I highlighted that in the Asia Pacific region, up to 60% of patients are core antibody positive. And vaccinating core positive patients has no clinical benefit, and we'll get back to that a little bit later. Also, if you're just vaccinating everybody and you're not testing for surface antigen, you're vaccinating people who are infected and they've been vaccinated. They think they're protected. So it's really important, in my opinion, as much as possible to get this triple test done before you vaccinate somebody. Now, I guess in I call it a compromised world, you bring somebody in, you draw their blood, you give them their first dose of their vaccine. At that moment, then you call them back after deciding if they need a second dose or not. But you need really good communication tools to make sure they come back, and you can identify if they're surface antigen positive, you get linkage to care, they're core antibody positive, they really need education about reactivation, and even potentially looking for a cold hepatitis B. So I think these are really, really important points about this testing vaccination process. And then there's a list here about pre-vaccination testing, but I'm going to broaden this out and just say, test everybody before you vaccinate them. Next slide, please. Okay, so let's walk through the tests in just a moment, but I just want to talk about prevalence. how many people can identify on a map high prevalence, intermediate prevalence, low prevalence? It's difficult. If you give somebody a map of the world, we have 200 countries, and you ask someone to put a puzzle together, name the countries and put the countries in the right place in a puzzle, it's bound to fail. We have trouble remembering where Tajikistan is, or Kazakhstan, or Azerbaijan. These are huge, huge challenges for us. The next issue is about immunosuppressive therapy. There are over 60 medications on the market today that modify the immune system. Then we're talking about another 100 drugs that are considered chemotherapy. There's a variety of immunosuppressive drugs and organ transplantation, a variety of other organs. And of course, people donate blood, and they should be tested, of course, for triple panel. We already know about pregnancy. We've discussed pregnancy during these echoes on multiple times. Next slide, please. So retesting individuals, this is be risk-based. What if you bring somebody in, you test them with triple, they're negative, you start the vaccination process, but they only get one of two or one of three vaccines. You need to test them again. They disappear. They come back a year and a half later. What do you do? I think in pregnancy, retesting would be important. And in high-risk individuals, retesting would also be important. And here's some risk behavior. Once people are fully vaccinated, I want to highlight that we don't recommend retesting those people. So if you finished your 2-dose or your 3-dose course of vaccine, those individuals don't need to be retested unless there's a super high-risk event that takes place. And we can talk about that during the Q&A. Next slide, please. So what about vaccination at birth? Very, very interesting. There is this whole issue about waiting up to 5 days when the first dose can be administered. You can wait until after discharge. All this permissive language has been removed. Next slide, please. And it's really, really important not just to test the mother, but to administer the hepatitis B vaccine, preferably within 12 hours. And I'd like to emphasize the Jourdain article that was published in New England Journal of Medicine about 3 years ago, where they gave the first dose within 2 hours of birth. And this theoretically could eliminate the need for hepatitis B immune globulin and potentially even eliminate the need for using tenofovir, TDF or TAF, during the 3rd trimester. Now, you might administer TAF or TDF, give the vaccine, but what about the mother who doesn't get tested until just before birth? There's really good data from this New England article that the 2-hour birth dose is extremely effective in preventing transmission, even in less than ideal settings without HBIG or without TDF. Next slide, please. It's very important to complete the vaccine series. Now, because of the way the vaccine is packaged, infants might actually get up to 4 doses. And that can be completed at 6 months of age, or should be completed, born to surface antigen positive mothers, 6 to 18 months of age, for instance, infants born to surface antigen negative mothers. I want to highlight that the core antibody in the mother is going to be core antibody positive. If she's surface antigen positive, that core antibody test can hang around for up to 14 months after delivery. So we really don't recommend testing the child for the triple panel with core antibody until after 16 months after birth. You, of course, can check surface antigen at any time after birth to make sure that the vaccine was effective. Core antibody, wait at least 16 months, 18 months. Next slide, please. Post-vaccination serologic testing, we mentioned this. Well, of course, surface antigen positive mothers for their infants. The mother's S antigen status is unknown. You're going to be doing retesting performed after completion of vaccine series in a child born to a hepatitis B positive mother. But not all babies get this. So it was in 2014, only 76% of patients had this post-vaccination serologic testing. We should be at 100%. As you know, in the US, there's over 1,000 children born each year who are surface antigen positive long-term, meaning our screening mothers and infant immunoprophylaxis is failing at a significant level. I mean, we are a wealthy country. We have, I think, a great healthcare system, even though there are inefficiencies. We should be close to zero in this country on hepatitis B transmission from mother to child. Next slide, please. So the ACIP guidance for perinatal HBV transmission, vaccination, prevention is listed here. We've gone over all this, the 24 versus 12 versus 2 hours. It's really important to get it as close to the time of delivery as possible. Fortunately, remove the permissive language for delaying the birth dose, which is a major step forward. I also like to highlight, I believe it's in 2022, Sherry may be able to comment during the Q&A, Gavi is going to be paying for / supporting that birth dose of hepatitis B for the first time after probably a decade or decade and a half of fighting with them to get that in board. And here we have the most common infections in the world, the most common cause of liver cancer, and Gavi did not include the birth dose of Hep B vaccine into their program. Very unusual. I think it just has to do with biases that are still existing in organizations. Next slide, please. So we've had hepatitis B vaccines available since the 1980s. They're initially plasma derived and actually plasma derived from HIV positive men, even though there's never been a case of HIV transmission from vaccines. They switched to a yeast derived, and then they started gradual implementation to vaccinate. And there has been a marked decrease in acute hepatitis B in the US. Universal vaccinations just around the corner. I'm hoping universal testing is just around the corner because risk-based testing for hepatitis B has been an incredible failure. And we should not go down a road where the bridge is crumbling. Next slide, please. Who should be vaccinated? Well, we've already answered that. Vaccinate all adults after testing all adults. Next slide, please. And we've got a lot of the risk. We can just click forward quickly here, Christine. There's a lot of people at risk, so why go through all of these steps? Why look at all these subgroups? Let's just vaccinate everybody after universal testing. Next slide, please. This again, just back to risk-based issues. And if we have universal testing, universal vaccination, you don't have to remember all these lists. Next slide, please. So we've got some very, very important here. VBI is not listed here because it's not yet available, but this is a 3-dose vaccine series, which has a much higher immune response. And when we talk about immune response, we're talking about antibody response. Unfortunately, we don't have a test for T-cell responses. You all are familiar, our main 2 arms of our immune system are B cells and T cells. These cells are easy. They make antibodies, and antibody measurement is easy. And this is a great way to show a B cell response and how high is the B cell response. And there is a relative level of protection, the higher the antibodies. But we've also shown that in people who get 2 or 3 doses of hepatitis B vaccine, no antibody response are still protected. Ulla Protzer from Germany has done some fantastic work, as well as other viroimmunologists, that show that our hepatitis B vaccines are T-cell vaccines, and they provide a robust immune response, even in the absence of an antibody response. Also, the antibody measurement's not perfect. We make lots of different antibodies, lots of different epitopes, and our antibody tests may not be measuring all of the antibodies that are produced. So every Combavax, Endurex, people are very, very familiar with these. Great safety profile with these. Nothing's perfect, just like we've learned with the coronavirus vaccine. Great safety, but there are side effects to all vaccines, but it's all about benefit versus risk. We've had advances here with Heplisav-B, a monovalent adjuvant response, which is a TLR9 adjuvant, which is a special arm of the immune system. This is for adults, not for children. 2 doses over 1 month. We have this Pediarix, which is a combination including hepatitis B, indicated for 6 weeks to 6 years. It's a 10 microgram dose. Then we have TwinMix. As you know, we have a hepatitis A epidemic in the US. It's great to be able to give A and B at the same time. We have this great efficiency. Hepatitis A just requires 2 doses, but in this case, you would give 3 doses and just get a little boost for your hepatitis A. Next slide, please. Vaccine safety, rare side effects, rare adverse reactions. pain at the injection site, low-grade fever is seen. There has been some yeast anaphylaxis, yeast-sensitive persons, but look at this incidence, about 1.1 per million doses administered, and this is a contraindication. Next slide, please. Updated hepatitis B vaccination. We've talked about everything here. Just a good summary. They did list Hepatitis B here, and VBI vaccine hopefully will be on this list with the next version, MMWR. Next slide. This just gives you more information about Hepatitis B. Next slide, please. Move through this rest of this quickly. Excellent safety profile equivalent to the comparison vaccines, which is Endurex in here. No difference in cardiovascular events. Next slide, please. A little bit more on safety here. Next slide, please. And safety profile comparable. This just talks about the number of subjects that were looked at. Next slide. And thank you for having me. Again, Christine, Evangelina, Kelsa. Appreciate all the VBI people being on here. The more people we have in the vaccine space, the louder the noise. We get to the rule of sevens. Bob Brown helped me with some of these slides. I've been honored to work with Hepatitis B Foundation, I think since 2013 as their medical director. It's been phenomenal growth for me personally and professionally. Catherine, we miss you. I think you're somewhere in Africa or on an airplane somewhere, so safe travels. And thank you for doing a Hepatitis B Echo.
Dr. Gish, for your presentation. Happy to open it up to questions. If anyone has questions for Dr. Gish. Any thoughts?
I'd like to ask a quick question, Christine. If it's okay, it's John Finkel. I was curious if you see any reason or any particular patient encounter where using a 3-dose vaccine as opposed to a 2-dose vaccine makes sense anymore today.
Well, it's a fantastic question, John, because we've got this incredible safety record going back, more than 2 decades with our 3-dose. So some people might say, well, we know more, we have more safety. And in this vaccine adverse environment, sometimes when you're hitting the corona world, which is very strange because these are the same people who got measles, mumps, and rubella, right? Vaccines. So you could come up with a safety explanation. Also, of course, when new vaccines come to market with VBI, it could be some price competition that comes into this too. The Hepatitis B, in terms of price modeling, ended up being a wash because it was 2 doses and you had less administration cost, but you had more cost up front for the vaccine itself. I've talked to the Dynavax people. I don't know why they put 5 vials in one of their distribution boxes for a 2-dose vaccine. It should be either 4 or 10 or something, an even number. So I was telling them to get their packaging better. So there's always room for more, participants or competitors or supporters of vaccine. And if you have callback system, the patients are coming to clinic regularly, 3-dose is easy. If you've got challenges with compliance, follow-up, mobile populations, 2-dose has a favorable profile.
Thanks. I was going to add that for our transplant eval patients, the 2-dose has been great because a lot of those patients don't have 6 months to wait to finish the series before transplant.
Great point.
Dr. Giss, I just want to reiterate what you were saying about rechecking titers. You mentioned that would only be in at-risk populations, but if someone has a delayed time between their first vaccine and their second and third, like you mentioned, you wouldn't recheck, you would just continue the series?
Yes, I mean that, 0, 1, 6, 0, 1, 2, these are relatively arbitrary dosing intervals. Now, if somebody's been more than 2 years out, again, I'm being arbitrary, I would probably start the vaccine series over, especially if they only got one dose of the vaccine. But I really want to have a couple important take-home messages. Don't check titers, don't boost, unless you've got very narrow, super high-risk population. And what's listed there would be somebody like a vascular surgeon or somebody who's constantly exposed to blood, HIV positive patients, also there's test and boosting, but then test and boost population is down to less than 1 or 0.1% of all patients. Let's waste Let's not waste time and money on testing and boosting. Let's get more people vaccinated. And the same message about this, Katie, in core positive patients. It still says in the guidelines to give them vaccine and see if they get an antibody response. And I say, so what? Number two, there's no peer-reviewed publications that boosting a core patient benefits them clinically. You cosmetically can sometimes raise the surface antibody a little bit, but it doesn't decrease the risk of reactivation. There's a false sense of protection if they've been vaccinated. Core positive have hepatitis B in their liver. False positive rate is 2 per 1,000 for the core antibody test. Patients need to be looked at for a Colt B. You had a great talk from our Stanford colleague on a Colt B a couple months ago, and also be warned about reactivation. 60 drugs on the market that modulate the immune system that could reactivate hepatitis B. That needs to be plugged in now to our thought process and our algorithm.
And how about age-based waning immunity? So if we're starting to have folks that are vaccinated at birth starting to age, the same at-risk populations should be being checked?
You know, they've got follow-up studies as far as 30 years out in Africa and Alaska. Brian McMahon, superstar in this area. There's a big study in Senegal that went out, I think 15 and then beyond 20 years. Their T cell and B cell memory is as good as the memory you had when you were 5 years old riding your tricycle. We've got great memory systems in our body.
Thank you, everyone, for your questions. Any other questions before we move on to Keith's presentation? All right. And feel free to enter questions into the chat as well.